Good morning. The subject of this talk today is about the transplants which took place in Europe during this pandemic. And the title of my talk is Europeans Died Waiting for Organ Transplants During Lockdown as Operations Dropped by at least 65%. In the United Kingdom first, the number of life-saving organ transplants carried out during lockdown fell by 65%. Some of the patients on the waiting list died due to the lack of services. Figures from the NHS Blood and Transplantation show that this year there were a total of 265 transplants from April 1st until the 31st of May 2020, compared to 702 for the same period last year. Some centers closed completely, others ran a skeleton emergency service, and many patients were told that they have been temporarily suspended from the waiting list. All living donations were cancelled due to the potential risk of infecting the donor, while deceased organ transplants continued at very reduced levels. The number of lung transplants fell from 40 at the same time last year down to 5. Liver transplants dropped from 149 to 73, and the number of heart transplants dropped from 22 to 20. Kidney transplants dropped from 361 last year to 165 this year. Experts say that the NHS staff and equipment being given over to focus on treating coronavirus, together with the added risk of carrying out transplant operations on patients where infection control could not be guaranteed, partly explain the fall in transplant operations. There was also an unexplained drop in donors. The news has raised concerns about the collateral impact of the pandemic on other NHS patients, many of whom needed life-saving interventions. Now, in the UK, Banerjee reported the first 7 cases of COVID-19 in transplant patients recipients in the South London hospitals. In this report, they discuss their first 7 cases of COVID-19 infection in kidney transplant recipients from South London. The median age of transplant recipients was 54 years. Of the 7 patients, 2 were managed on an outpatient basis and stayed at home, with the remaining 5 requiring hospital admission. 4 among the latter required ITU admission, and 1 was being managed in the renal ward. Of 4 patients sent to ITU, 2 needed intubation and ventilation. The other 2 were managed with oxygen through mask and non-invasive ventilation only. There was sadly 1 death in this small series of 7 patients, therefore a mortality rate of 14%. Managing immunosuppression in these patients is challenging and should take into account the age, the severity of COVID-19 infection, associated with comorbidities, and the time post-transplant. 2 of their patients presented within 3 months after transplantation, and 1 presented within 2 weeks. They suggested at that time suspending kidney transplantation during the COVID-19 pandemic, particularly for high-risk older recipients with comorbidities. Rigorous adherence to hand hygiene, recommended isolation procedures, and regular assessment, virtually or on the telephone, of transplant patients would help indeed reduce the incidence and facilitate management of mild to moderate cases, in the community as they did in 2 of their 7 transplanted patients. The COVID-19 UK register has been set up by the UK Transplant Registry, held by Organ Donation and Transplantation, to record all cases of renal transplant recipients presenting with COVID-19 infection and analysis of the registry data, which will help clinicians make informed consent and informed decisions about management of these complex patients in these uncertain and rapidly evolving times. Now, moving to Greece, Stefan Ezagian from Greece reported that additional dilemmas rise regarding the potential discontinuation of immunosuppression regimens to improve their immune response to the infection, which must be weighed against the potential adverse event of the transplantation rejection. Nevertheless, immunosuppression regimens were fully maintained in many of the reported kidney transplant recipient cases. In all these cases, the authors hypothesized that the immunosuppression regimens may have prevented the overt immune response, manifesting as a cytokine storm that is believed to be responsible for many of the severe manifestations of the disease, such as acute respiratory distress syndrome and multi-organ failure, as reported by Mehta et al. In contrast to other infectious diseases where only the transplant recipient is at risk, the COVID-19 could rapidly spread amongst other medical personnel, resulting in serious consequences to the community. As a result, it becomes imperative that both patients and medical professionals strictly adhere to all appropriate safety measures geared towards minimizing transmission in order to ensure that transplant programs can continue to operate uninterrupted for as long as possible without placing the patients or the community at risk. In Italy, Roberta Angelico has been one of the first to report in the country, in Italy, dealing with the outbreak of COVID-19. And severe measures have been adopted to limit the viral transmission. The spread of the COVID-19 may have several implications in organ transplant activity that physicians should be aware of. The initial experience gained during the COVID-19 outbreak shows that around 10% of infected patients in Italy needed intensive care management to overcome the acute respiratory distress syndrome. Due to the exponential rise of the infected patients, they faced an actual rise of saturation and intensive care unit beds. A restriction in the number of ITU beds available for both donors and transplant recipients may unfavorably influence the overall donation activity, which indeed has been the case, and eventually lead to a reduced number of transplants. The preliminary Italian data showed that a 25% reduction of procured organs has already occurred during the first weeks of the COVID-19 outbreak. Again, and also in Italy, Francesca Martino considered that there was insufficient evidence available to consider kidney transplantation as a safe procedure in COVID-19 pandemic areas, in emergency situations, in case of no vascular access, unfeasible dialysis, or a hyperimmune state. The benefits might indeed outweigh the risks of a kidney transplant. Therefore, decisions should be made on a case-by-case basis with concerns shared among the transplant team and patient after careful assessment of the risks and benefits. In the meantime, each case should be carefully discussed and scrutinized by the entire transplant team, and a dedicated consent from who form would help patients to make well-informed decisions. In the Netherlands, Vries and al. First documented cases of COVID-19, which counts in the Netherlands 17.2 million inhabitants. And this was on the 27th of February 2020. In less than 60 days, despite increasingly stringent measures of the Dutch government to halt the spread of the infection, 28,000 individuals had tested positive for severe acute respiratory syndrome. 9,000 patients have been admitted to hospitals across the country, so it's quite a large number. The total amount of all organ transplants markedly decreased from 100 to 150 to 40 transplants per month in the first COVID-19 months, a decrease of 65%. This is in contrast to the COVID-19 outbreak in Italy, where the activity remains stable for each type of solid organ. However, here the first 4 weeks for the outbreak was taken into account, while they have taken the period 27th of February till the 15th of April. Pancreas transplant decreased to 0, and renal transplants from 80 to 100 to 20 per month. The number of liver and lung transplant markedly declined from a mean of 16 to 8 per month and from 18 to 7 per month, respectively, a decrease of approximately 50%. There was no pediatric transplant activities in the first COVID-19 months. In Spain, Mario Fernandez Ruiz reported the preliminary experience with 18 solid organ transplants, kidneys, liver, and heart recipients diagnosed with COVID-19 at the tertiary care center in Madrid. The median age at diagnosis was 17 plus or minus 12, and the median interval since transplantation was 9 years. Fever and the radiographic abnormalities in form of unilateral or bilateral multifold constellations were the most common presentations. In Sweden, in Gothenburg, they reported 12 case series totaling 204 kidney transplant recipients with COVID-19. Most patients were men. The most frequent symptoms were fever, cough, dyspnea, and at admission, over 70% of the patients had abnormal radiological findings. The leukocyte counts were in the lower normal range. The C-reactive protein, ferritin, and dimer were consistently increased. The treatments included lowering immunosuppression, hydroxychloroquine, antivirals, tocilizumab, and intravenous immunoglobulins. 31% of the patients were admitted to the intensive care units and 16% required intubation. The overall mortality was 21%, and the patients who died were significantly older than those who survived. Ladies and gentlemen, in conclusion, I believe that ideally patients should have been offered the choice to have a transplant if they could have had one, knowing all the risks. Patients will have died as a result of this. Hospitals shut down because of the pandemic, and these patients are part of the collateral damage. Transplant waiting list patients have been disadvantaged by the COVID pandemic, and some may never receive a transplant as a result. This has been a vital learning experience, and we need to plan for the future. For example, how to run hospitals more flexibly so that patients in higher COVID risk areas could be treated in lower COVID risk areas. We now need to adapt as quickly as possible to the changing circumstances, because for every transplant that does not go ahead, a patient suffers or even dies as a result. Every service operates on a knife edge and close to the limits in care, and it doesn't take much to expose its fragilities as this pandemic has done. The key is vigorous and robust infection control. Thank you very much.